Welcome back to The Deep Dive. This is the show where we take the complex, the really high-stakes stuff, and we pull out the clinical blueprints you actually need to succeed on the wards. And today we were diving deep into the absolute foundation of hospital care, managing the acutely deteriorating patient.
That's right. And look, this isn't just theory. This is really the core curriculum for surviving and hopefully thriving when you're on the medical take. We're distilling the critical insights from Chapter 9 of Davidson's medicine on acute medicine and critical illness.
And our mission for you listening is to really synthesize this knowledge. We're not just reading lists today.
No, not at all. We're building what we're calling clinical anchors. Mental shortcuts that should just spring to mind the second a monitor starts alarming.
So you have the blueprint in your head before you even walk in the room.
Exactly. We're going to cover a lot. The big presentations, chest pain, breathlessness, then how to assess deterioration with things like the DNWS2 score, and then the big hitters from ICU, sepsis, ARDS, cardiac arrest.
Okay, let's unpack this. We'll start with the big picture. This sort of evolving, slightly paradoxical role of the acute care physician.
It really is a fascinating paradox because as medicine gets more and more specialized, you've got your cardiologist, your nephrologist.
Right, everyone has their niche.
The need for a highly skilled generalist just goes through the roof. In the U.S., they call them hospitalists. Here in the U.K., general physicians. But their skill is in that undifferentiated presentation.
The patient who just says, I feel poorly.
Exactly.
Yeah.
And they've got 7 chronic conditions, a bag full of meds. The specialists can't really engage until there's a diagnosis. The hospitalist's job is to get that diagnosis.
So they're the ultimate medical detective, really.
They have to be. Their core skill is integrating everything, the history, the polypharmacy, the chronic stuff, to get a prompt diagnosis and start treatment. And the goal is twofold. Minimize error, but also, and this is just as important, minimize over-investigation.
Which brings us to that first huge decision point. Do we admit this patient, or can we manage them in something like an ambulatory care setting?
And that's always a complex decision. It's not just about the illness. It's about the patient's physiological reserve. Do they have dodgy kidneys or a weak heart? Do they need urgent imaging? And of course, their social situation. A patient might be medically stable, but have no support at home, which means they have to come in.
But there's a big push towards this ambulatory care model, right? Doing complex workups without an overnight stay.
A huge push. And we can kind of anchor the right patients for this into 4 main groups.
Okay.
First, there's diagnostic exclusion. This is for your low-risk patient. Think low-risk chest pain. You do serial ECGs, troponins, and if it's all clear, send them home safely without taking up a bed for 24 hours.
Right. Rule out the scary stuff quickly.
Exactly. Second is low-risk stratification. This is when you know the diagnosis, like community-acquired pneumonia, and use a score like CURB-65 to confirm it's mild enough for home treatment with oral antibiotics.
Okay, so that makes sense. What's the third group?
Specific procedures. Things that need expertise, but not a whole admission. Like, draining a small pleural effusion, or replacing a PEG tube.
Got it. And the last one?
Outpatient groups with infrastructure. So conditions like cellulitis or a DVT. The idea is you do the Doppler scan for the DVT, right there and then you start the anticoagulation and the patient goes home. It's fast, efficient, and safe for the right person.
But the key is that careful patient selection. This isn't for a frail patient who struggles to get to the hospital once, let alone multiple times.
Absolutely not. And speaking of using resources wisely, we have to touch on this huge issue of medically unexplained or functional symptoms. The source says this can be up to half of all new hospital visits.
Half? That's staggering.
It is. And if the clinician doesn't really understand functional disorders, they can send the patient down this rabbit hole of invasive, ultimately harmful over-investigation. Recognizing when to stop is a core skill.
Okay, so from that broad assessment, let's get into the nitty-gritty. The structure every clinician needs when a patient is deteriorating.
This is the full, comprehensive critical care review. It goes way beyond the initial ABC.
This is the ABCDEFGHI checklist. You have to have this burned into your memory.
It's your safety net. It stops you from missing something vital when you're dealing with multi-organ failure. Let's walk through it.
Okay, so A is airway.
Is it patent? Is there stridor? But if they're intubated, the absolute key check is the end-tidal CO2 trace. That waveform tells you if you're ventilating both lungs, a flat line is a catastrophe.
B for breathing.
You're looking at the whole picture, rate, depth, how much support they're on, You have to review the ventilator settings, the latest blood gas, and the chest x-ray.
See, circulation.
So this is more than just heart rate and blood pressure. It's about perfusion. Are their peripheries warm or cold? What's the lactate doing? And critically, what's their urine output? That tells you if the kidneys are getting enough blood.
And you're also assessing how much support they need, fluids, inotropes, that sort of thing.
Exactly. Then D is for disability, GCS of course. But you have to actively screen for delirium, check the pupils, and this is a big one review, the sedative drug doses. Iatrogenic oversedation is a really common reason for a patient to look like they're deteriorating.
Good point. E is for enteral exposure.
Right. How are they being fed? Is the gut working? And exposure means you've actually examined the whole patient. Roll them over, check their back for pressure sores, look for a new rash.
F, fluids and renal.
Yep. What's the 24-hour fluid balance? Are they puffy with edema? Check the urine, check the latest UNEs. Simple stuff, but vital.
G is glucose.
Always.
Yeah.
Always check the blood sugar. Hypoglycemia can look exactly like a catastrophic stroke, but it's fixed in seconds.
H, hematology.
What's the hemoglobin? What are the platelets? Is there any sign of bleeding from anywhere?
And finally, I4, infection.
What's the temperature trend? What are the inflammatory markers doing? What antibiotics are they on, and for how long? And the million-dollar question, is the source of the infection actually controlled?
That is an incredibly thorough system. If you do that every day, you're just not going to miss things.
That's the whole point. It forces a structured, system-by-system review.
Okay, let's do a quick check-in for you listening. Thinking about that 9-point ABCDEFGHI checklist, which single component is most likely to reveal an error caused by a previous clinician's decision? A little hint. Think about iatrogenic causes of neurological change. If you're not sure, just rewind and listen to D&I again.
Good one.
Now let's talk about the monitors at the bedside, the simple devices that can tell some dangerous lies.
They absolutely can. Let's start with the pulse oximeter, the SpO2 probe. Everyone knows it measures oxygen sats. But the trace itself is a waveform, a plethysmograph. If that trace is flat, it means the machine can't even find a pulse. That's a huge sign of poor peripheral perfusion.
But the sources really stress the flaws, what they call the oximeter's disguises. These are things that can make you falsely reassured.
And you have to memorize these. The first and deadliest is carboxyhemoglobin from carbon monoxide poisoning.
Right, the smoke inhalation victim.
The COHE causes a falsely high SpO2 reading. The monitor might say 100%, but the patient's blood is full of poison. It's because the oximeter, with its 2 wavelengths of light, literally cannot tell the difference between oxyhemoglobin and carboxyhemoglobin.
That is terrifying.
It is. The second disguise is methemoglobinemia. This tends to make the SpO2 read a fixed value, around 85%, no matter what the real saturation is. And third, just remember it gets much less accurate below about 80% saturation.
And the one thing it's not affected by, which is a common trick question.
Hyperbilirubinemia. Jaundice does not affect the SpO2 reading.
Okay, let's move on to capnography, the end-tidal CO2 monitor. This is all about ventilation, not oxygenation.
Correct. And the shape of that waveform is packed with information. A normal trace has a steep upstroke and a plateau.
Like a little box.
Exactly. But if you see a shallow upstroke, sort of a shark fin shape, that's a massive clue for bronchospasm, asthma, COPD.
And what if the whole waveform just starts getting smaller and smaller?
Now, that is the key anchor. If the capnography waveform is shrinking, it means less CO2 is being delivered to the lungs. The lungs are fine, but the blood flow, the cardiac output, is critically low.
So a breathing monitor is telling you about the heart pump.
It's a beautiful link between B and C, and if the line goes completely flat, it's the worst case. No ventilation. Either the tube is out, it's in the esophagus, or the patient is in cardiac arrest.
Okay, so that's capnography. What about the arterial line?
Well, beyond the continuous BP, the area under that pressure curve is proportional to the stroke volume. So if you see really narrow, spiky peaks, that suggests a low stroke volume. Not much blood getting pushed out with each beat.
And finally, the invasive one, central venous pressure, or CVP.
The CVP is basically the pressure in the big veins just before the right side of the heart. It's a rough guide to volume status. If it's really high, it suggests either fluid overload or that the right ventricle is failing to pump blood forwards, maybe because of a big PE.
But a normal CVP doesn't mean the patient will respond to fluids.
Exactly. A low CVP strongly suggests they need fluid, but a normal or high CVP is much harder to interpret. You have to look at the whole clinical picture.
Okay, let's pivot to the things you see walking through the door of the emergency department. Let's start with chest pain.
The goal here is always the same. Separate the 5 life-threatening causes from everything else. And for that, we use what Davidson calls the balance of evidence, using the patient's story to tip the scales.
Let's apply that. Location and character of the pain.
Ischemic pain is typically central, heavy, crushing, and radiates to the neck, jaw, or arms. Pain that goes straight through to the back like a spear, that's highly suspicious for an aortic dissection.
What about pain that's sharp?
Sharp, catching pain that's worse on a deep breath or a cough, that's pleurisy. It points to something like a PE or pneumonia. Pericarditis can also be sharp, but it often gets better when the patient leans forward.
And onset. This feels like the big differentiator.
It is, and MI develops over minutes. But the catastrophic things, aortic dissection, a massive PE, a pneumothorax, they're sudden. Maximal pain within seconds. The patient could often tell you the exact moment it started.
And pain after exertion is rarely cardiac.
Very rarely. That's usually musculoskeletal.
What about associated features? The other clues.
Big life threats trigger a massive sympathetic response. So you look for sweating, nausea, that feeling of impending doom, what they call anger anomie. And breathlessness with an MI is a sign the left ventricle is acutely failing.
On examination, what's the one thing you absolutely must check for?
Besides looking for signs of shock or heart failure, you have to check for asymmetrical pulses or a difference in blood pressure between the two arms. That is a massive red flag for aortic dissection.
Okay, investigations. ECG is first, always. Then biomarkers.
Yes. A STEMI on the ECG needs immediate reperfusion. For biomarkers, we measure troponin. But the key is, if the first one is negative, you have to repeat it 6 to 12 hours after the peak of the pain.
Let's anchor the pitfalls of troponin. It doesn't just mean heart attack.
Critically important, troponin is a marker of heart muscle injury, not just a blocked coronary artery. So a massive PE will raise troponin from right heart strain. Sepsis will raise it from supply-demand mismatch. Aortic dissection, renal failure, lots of things can cause a troponin leak.
So the context is everything.
The story is king. Which brings us to our key takeaway on chest pain. Use the balance of evidence. If the story screams crushing, exertional, radiating pain, you treat it as ischemia until proven otherwise, even if the first ECG and troponin are normal.
All right, next up. Acute breathlessness. This is where you might need to treat before you investigate.
Absolutely. Your immediate triage priority is to rule out and treat 3 things: airway obstruction, anaphylaxis, and tension pneumothorax. You do not wait for tests if you suspect any of these.
Okay, assuming those are ruled out, how do you differentiate the other causes quickly?
You look for the classic patterns. Pulmonary edema. You'll see signs of fluid overload. Raised JVP, crackles at the lung bases, and often a wheeze they call cardiac asthma.
Asthma or COPD.
That's more of a prolonged expiration and expiratory wheeze, usually with a known history. A pneumothorax will have a hyperresonant percussion note and absent breath sounds on one side.
And what about a PE?
This is the tricky one. Often with a PE, the patient is incredibly breathless, but the chest exam is completely normal. The breathlessness feels out of proportion to your findings.
The ABG, the arterial blood gas, gives you information the SATS probe can't.
It's critical. It tells you if the patient is retaining CO2, which means they're tiring out. That's type 2 respiratory failure. And the rate of rise of that CO2 is more important than the absolute number. It also helps you spot metabolic acidosis or, conversely, psychogenic hyperventilation where the CO2 is incredibly low.
There's a rule mentioned for ruling out PE, the PERC rule.
Yes, the pulmonary embolism rule-out criteria. It's a set of 8 criteria. If your pretest probability is already low and the patient meets none of these criteria, things like age over 50, heart rate over 100, unilateral leg swelling, you can safely rule out a PE clinically without even doing a D-dimer.
Okay, quick check-in for our listeners. Your patient is acutely breathless, hypotensive, and has absent breath sounds on the left with a hyperresonant percussion note. What's the diagnosis, and what is your very first intervention? Don't say get a chest x-ray. If you're not sure, rewind.
A classic.
Let's move to anaphylaxis. You call this the endothelial riot.
It is a riot. It's a life-threatening systemic allergic reaction, and the risk of death is much higher if adrenaline is delayed or if the patient has underlying asthma.
Can you walk us through the pathology of that riot at the cellular level?
So an allergen, say a peanut protein, cross-links IgE antibodies on the surface of mast cells. This triggers a massive explosive release of histamine and other mediators.
And histamine causes 2 big problems.
2 devastating immediate problems. First, profound systemic vasodilation, which drops the blood pressure through the floor. Second, it makes the capillaries incredibly leaky, so fluid pours out of the blood vessels and into the tissues. That's what causes the angioedema and the intravascular volume depletion. The combination is circulatory collapse.
What are the clinical signs that scream, give adrenaline now?
Itching, flushing, widespread hives, swelling of the lips and tongue, wheeze or stridor, severe hypotension, and that profound psychological sense of impending doom.
And the management is all about speed.
Time is everything. It's adrenaline, given intramuscularly into the thigh. 0.5 milliliters of 1 in 1,000 solution. The IM route is crucial because in shock, peripheral circulation is poor, so IV or subcutaneous routes are unreliable. You repeat it every 5 to 10 minutes if you need to.
And you're also giving fluids and oxygen.
Immediately. High-flow oxygen and big IV fluid boluses to try and fill the leaky tank.
What about the secondary drugs, antihistamines and steroids?
They're important, but they are secondary. They don't save a life in the first 2 minutes. The antihistamine blocks the immediate effects of histamine, and the steroids, the glucocorticoids, dampen the later inflammatory response and are really important for preventing a rebound reaction hours later.
And long-term, what's the crucial safety netting advice?
Specialist referral is mandatory to find the trigger, and the patient must be prescribed 2 self-injectable adrenaline devices and be taught, along with their family, exactly how and when to use them.
Okay, let's switch gears to syncope, or the blackout. The first job is to define what the patient actually means by that.
Absolutely. Is it true syncope, which is a sudden loss of consciousness from reduced blood flow to the brain? Or is it pre-syncope, that feeling of about to pass out?
Yeah.
Or is it vertigo or a seizure or just a fall? You have to clarify.
What are the 3 big mechanisms for true syncope?
First and most dangerous is cardiac syncope. This is from either a mechanical problem like severe aortic stenosis or an arrhythmia, the heart going too fast or too slow. These are often sudden, with no warning. Neurocardiogenic or vasovagal syncope. This is that classic faint triggered by pain or emotion. It's an abnormal autonomic reflex that causes the heart to slow down and the blood vessels to dilate, causing hypotension. Crucially, this one usually has a warning. The patient feels sweaty, nauseous, clammy.
And the third one is very common in older patients.
Postural hypotension. That's when the blood pressure drops on standing because the body's normal vasoconstriction reflexes are impaired. Common in the elderly, people with diabetes, and on certain medications.
The big differential is often between syncope and a seizure.
Yes, and the key is what happens after the event. With syncope, the patient is usually pale, recovery is very quick, less than a minute, and they're not confused afterwards. With a seizure, the unconsciousness is longer, they might be cyanosed, and the hallmark is the postictal state, that period of prolonged confusion, headache, or delirium after they wake up.
So it's the recovery that tells the story. For investigations, what's the one test everyone with syncope gets?
A 12-lead ECG. It's mandatory. You're looking for conduction problems, a long QT interval, signs of an old MI. If the events are really frequent, a 24-hour tape is useful. If they're rare, you might need an implantable loop recorder.
So our key takeaway for the blackout is that your first question isn't what happened. It's more like, what did it feel like? Were you fully unconscious or just dizzy?
Precisely. That distinction sets you on the right path.
Okay, next up is headache, a very common complaint. But our job is to find the needle in the haystack.
Right. Find the small minority with a serious secondary cause. And for that, we have to be absolutely ruthless in checking for red flags.
What's the number one most urgent red flag?
Sudden onset. The thunderclap headache. Pain that reaches its absolute maximum intensity within 5 minutes or even less. That screams subarachnoid hemorrhage and needs immediate investigation.
What are some of the other red flags?
Focal neurological signs, fever, neck stiffness, a rash, or a headache that's worse when waking up lying down or coughing, which suggests raised intracranial pressure. And a brand new headache in anyone over 60, you have to think about temporal arteritis.
For suspected meningitis, what's the key investigation pathway?
The diagnosis is confirmed by lumbar puncture, but you must not delay starting antibiotics to get the LP done. If you're worried about raised ICP, you do a CT scan before the LP to make sure it's safe.
And for that thunderclap headache?
CT head first. If it's done within 6 hours of the onset, it's very sensitive for a subarachnoid hemorrhage. If that CT is normal, you still need to do an LP after 12 hours to look for xanthochromia, the yellow staining of the CSF from old blood.
Okay, let's move down to the legs. Unilateral leg swelling. The big worry is a DVT.
Always the primary concern. But there are important mimics. Sudden, sharp pain could be a simple muscle tear or a ruptured Baker cyst. But the one you can't miss is compartment syndrome.
How does that present?
It's an exquisitely painful, tense, swollen limb, usually after trauma. The key sign is severe pain on passive stretching of the muscles in that compartment. And a crucial anchor point. Absent pulses are a very late sign. Don't wait for them.
So how do we work up a suspected DVT?
You start with a clinical probability score, like the Wells score. If the score is low, you do a D-dimer test. If that's negative, you've safely ruled out a DVT.
And if the Wells score is high or the D-dimer is positive?
Then you move straight to definitive imaging, which is a Doppler ultrasound scan.
Are there any big pitfalls with the D-dimer test?
Two big ones. First, its sensitivity drops off if the symptoms have been there for more than about a week. Second, you should not use D-dimer in pregnancy. It's often non-specifically raised anyway.
Yeah.
You have to rely on clinical suspicion and imaging.
Right. And finally, for this section, the acute abdomen.
The key here is to think about the underlying process. Is it inflammation, like appendicitis, which starts vague and then localizes? Is it perforation, which is sudden, agonizing, generalized pain?
Or obstruct.
Right, which is colicky, where the patient's writhing around. Or is it ischemia, which is often severe pain that seems completely out of proportion to your physical exam findings?
And if you find signs of peritonitis guarding rebound tenderness, what's the immediate priority?
That's a surgical emergency. The priority is what we call the surgical triad. Resuscitation, first fluids, oxygen, antibiotics, then source control, which means finding the cause, and then definitive treatment, which is usually surgery.
Okay, let's move into part 3. How we identify deterioration on the wards before it becomes a catastrophe.
This is all about rapid response systems. The whole goal is to catch physiological decline early to reduce the number of in-hospital cardiac arrests.
And the tool for that in the UK is the National Early Warning Score, new WS2.
Exactly. It's a score that allocates points for abnormalities in 6 things. Respiratory rate, oxygen sats, temperature, blood pressure, heart rate, and level of consciousness.
What are the key trigger scores we need to know?
A total score of 5 or more is the urgent response threshold. That requires an immediate review by the medical team. A score of 3 in any single parameter is also a trigger.
And the really high-risk one?
A total score of 7 or more. That's the emergency response threshold. That needs an immediate assessment by a critical care competent team, and you should be thinking about transfer to a higher level of care.
Once that alarm is raised, the response team arrives and uses the immediate assessment protocol, C, A, B, C, D, E.
Right, and notice the first C is different from the usual ABC. It stands for control. Control any catastrophic bleeding. Stop a life-threatening arrhythmia. Deal with the immediate killer first.
Then A and B, airway and breathing.
If the patient is talking in full sentences, they're probably okay. If not, secure the airway, get them on oxygen, get a blood gas.
C for circulation.
Focused exam. HR, BP, JVP. But a great clinical anchor is to check the peripheral pulses. As shock progresses, you lose the radial pulse first, then the brachial, then the femoral. It's a marker of severity long before the central blood pressure plummets.
D for disability.
Full GCS. And always, always, always check a capillary blood glucose.
And E for exposure and evidence.
Get the patient fully undressed, finish your exam, and start gathering the story from the notes in the drug chart.
Let's talk about the specific signs of deterioration, starting with the most sensitive one.
Tachypnoe, a rising respiratory rate. It's the earliest and most sensitive sign that something is wrong. It can be a primary lung problem, but more often, it's the body's response to a metabolic acidosis.
So the patient is breathing fast to blow off acid.
Exactly. Lactic acid from sepsis or keto acids from DKA. The ABG tells you how bad it is. And here's an anchor for you. A lactate over 4 or a base deficit over 10 should trigger an immediate call for senior help or critical care.
Okay, next. Hypoxemia. We need to be clear about the terms here.
Right. Hypoxemia is low oxygen in the arterial blood. Hypoxia is inadequate oxygen at the tissue level. You can have tissue hypoxia without hypoxemia, for instance in cyanide poisoning, or if the cardiac output is zero.
And when we're giving oxygen, we now know that too much can be harmful.
Very much so. So oxygen has to be prescribed with clear targets. For most patients, that's 94 to 98%. But for patients at risk of type 2 respiratory failure, like severe COPD, the target is much lower, 88 to 92%.
Why is giving too much oxygen to a COPD patient so dangerous?
It's because it knocks out their hypoxic drive to breathe, but more importantly, it worsens the ventilation-perfusion mismatch in their lungs, causing a massive rise in CO2 that can lead to narcosis and respiratory arrest.
Okay, tachycardia, heart rate over 110.
In a sick patient, this is usually a response to something else, sepsis, bleeding, fever. It's rarely a primary cardiac problem. Heart rate over 160 is an emergency. The key is to treat the underlying cause, not just try to slow the heart down with drugs that might make them more hypotensive.
And speaking of hypotension, how do we define that?
It has to be relative to the patient's usual blood pressure. But our target is usually a mean arterial pressure, or MAP, of over 65 mmHg. That's the pressure needed to keep the kidneys and other vital organs perfused.
When does hypotension become shock?
Shock is when oxygen delivery fails to meet the body's metabolic demand. Hypotension is a sign of shock, but shock is defined by evidence of tissue hypoperfusion. A rising lactate, a rising base deficit, poor urine output.
And before you pour fluids into a hypertensive patient, what's the first thing you check?
The drug chart. Always rule out an iatrogenic cause. Did they just get a dose of an antihypertensive?
And our last sign of deterioration, a decreased conscious level.
This is a true emergency. The immediate risks are loss of airway and brain injury. A GCS of 8 or less, or a motor score of less than 5, means you have to seriously consider early intubation to protect their airway.
What are the two immediate reversible causes you have to check for?
Glucose and sodium. Always. Severe hypoglycemia or hyponatremia can cause profound coma, but are easily fixed if you find them, miss them, and the brain damage can be permanent.
So the key takeaway here is to use the vital signs as your starting point. Tachypnoea points to acidosis, tachycardia to volume loss or sepsis. Hypotension means shock until you prove otherwise.
And never forget the simple checks: glucose and the drug chart.
Okay, now for part 4. We're getting into the major critical illness syndromes, starting with the big one, sepsis.
Sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. That's the formal sepsis 3 definition. Septic shock is when, despite adequate fluid resuscitation, the patient remains hypotensive and has a high lactate.
Let's go back to that idea of the endothelial riot. What's actually happening to the blood vessels?
The initial infection triggers this massive uncontrolled inflammatory cascade, and a key part of that is the massive production of nitric oxide, which is a powerful vasodilator. This causes the blood vessels to become pathologically relaxed and floppy, a state we call vasoplegia.
So they don't respond to fluids properly?
Not at all. And at the same time, the endothelium gets leaky, causing fluid to shift out of the circulation, and the coagulation cascade gets activated, causing tiny clots or microthrombi to form everywhere. It's a perfect storm for multi-organ failure.
Lactate is our key biomarker here. Why is a really high lactate, say over 8, so ominous?
Because it's a direct measure of how severe the tissue hypoxia is. It means the cells have switched to anaerobic metabolism. A lactate that high carries an incredibly high mortality rate. What we want to see is lactate clearance, the level coming down with resuscitation. That tells us we're winning.
Management is all about speed, and it's guided by the sepsis 6.
Which have to be delivered within 1 hour. Give oxygen, take blood cultures, give IV antibiotics, measure lactate, start 5E fluids, and measure urine output.
And the most time-critical part of that is the antibiotics.
Absolutely. Anchor this fact in your brain. Every hour of delay in giving appropriate antibiotics in septic shock is associated with a 5 to 10% increase in mortality.
Let's talk about fluids and pressors. The guideline is often 30 milligrams of crystalloid. But what if the patient is still hypotensive after, say, the first liter?
That's a great question. In a patient with known heart failure, you have to be cautious. But if you have a patient in clear septic shock and they are not responding to that initial fluid challenge, you should not delay starting a vasopressor.
So start noradrenaline early.
Yes. Don't wait until you've given 3 or 4 liters of fluid and the patient is puffy and waterlogged. The problem is vasoplegia, so you need to treat it with a vasoconstrictor. Noradrenaline is the first-line choice.
And you can't have sepsis treatment without source control.
It's fundamental. You have to find and deal with the source of the infection. Drain the abscess, remove the infected line. No amount of drugs will work if there's a pocket of pus that isn't dealt with.
Okay, next syndrome. Acute respiratory distress syndrome, or ARDS.
This is the most severe form of acute lung injury. The Berlin definition describes it as acute onset, bilateral opacities on the chest X-ray, the classic whiteout, and severe hypoxemia that isn't explained by heart failure.
Pathologically, what's causing the lungs to fail so badly?
It's a diffuse inflammatory injury. The capillaries in the alveoli become incredibly leaky, and protein-rich fluid floods the air spaces. This inactivates surfactant, causing the alveoli to collapse, and makes the lungs incredibly stiff and hard to ventilate. The result is a massive shunt, where blood flows through the lungs without picking up any oxygen.
And the management is all about supporting the patient while trying not to cause more damage with the ventilator.
Yes, it's all about lung protective ventilation. We know that ventilators can cause damage. We call it VLI, or ventilator-induced lung injury. The cornerstone of preventing this is using low tidal volumes, around 6 millimol per kilogram of predicted body weight.
Which means you often have to accept a higher CO2 level.
Exactly. We call it permissive hypercapnia. We tolerate a high PaCO2 as long as the pH stays above about 7.2. It's a trade-off to protect the lungs from being overstretched.
Is there one measurement on the ventilator that's even more important than the pressures?
Yes, the driving pressure. That's the plateau pressure minus the PEEP.
Yeah.
It represents the pressure that's actually distending the fragile open alveoli. Keeping that driving pressure below 15 is probably the single most important thing we can do to protect the lungs.
And for really severe ARDS?
We use advanced techniques like prone positioning, turning the patient onto their front, which helps recruit collapsed lung tissue. And for the most severe cases, we use VV ECMO, which is essentially an artificial lung outside the body.
Let's move to the heart. Cardiogenic shock.
This is when the heart pump itself fails, leading to hypoperfusion. Most commonly, it's after a massive heart attack, but it can be from other causes like a huge PE or acute valve failure.
And it creates this lethal downward spiral.
It does. The weak heart leads to low blood pressure. The low blood pressure reduces blood flow to the coronary arteries themselves, which makes the heart muscle even more ischemic and weaker. It's a vicious cycle that's very hard to break.
And finally, cardiac arrest.
The goal here is ROSC, return to spontaneous circulation. The ALS algorithm is what guides us, and it all depends on the rhythm you see on the monitor.
Let's break that down. First, the shockable rhythms.
That's ventricular fibrillation, VF, and pulseless ventricular tachycardia, VT. The only thing that fixes these is electricity. So immediate defibrillation, followed immediately by 2 minutes of high-quality CPR. You give adrenaline every 3 to 5 minutes.
And the non-shockable rhythms.
That's PEA, pulseless electrical activity, and asystole. A shock is useless here. It's immediate CPR and adrenaline while you desperately search for a reversible cause.
And for that, we have the essential mnemonic, the 4 H's and 4 T's.
You have to know these off by heart. Hypoxia, hypovolemia, hyperkalemia, hypothermia, those are the H's. And the T's are thrombosis, coronary or pulmonary, tension pneumothorax, tamponade, and toxins.
Once you get ROSC, the work isn't over.
Not even close. Post-resuscitation care is meticulous. We use targeted temperature management, keeping the patient cool to 36 degrees for 72 hours to protect the brain. We tightly control blood pressure, oxygen, and CO2 levels.
Okay, that brings us to the final part of our deep dive, the really tough decisions in critical care.
Yeah, starting with the decision to admit someone to ICU in the first place. The source is very clear. Intensive care is a painful, devastating experience. It's a huge loss of autonomy. So the admission has to be morally justifiable.
Meaning there has to be a realistic hope of a meaningful recovery.
Exactly. A quality of life that justifies the suffering of the treatment. This requires incredibly honest conversations. And when you're talking about risk, the evidence shows it's much better to use natural frequencies than percentages.
Can you give an example of that?
Instead of saying there's a 10% chance of survival, you say if we had 100 people in your exact situation, about 10 of them would survive and leave the hospital. It's much easier for families to grasp.
Let's quickly touch on the high-end support systems, starting with renal support.
The main thing to know is that we often use continuous renal replacement therapy, or CRRT, in ICU because it's gentler on the blood pressure than standard intermittent dialysis. The good news is most patients who survive their critical illness will get their own kidney function back.
And for cardiovascular support, the most invasive monitor is the Swan-Ganz catheter.
The pulmonary artery catheter. It's not used as much anymore, but it gives you incredibly detailed information. It can measure the filling pressure of the left side of the heart, the wedge pressure.
And how does that help?
It's brilliant for differentiating complex shock states. For example, if a patient has a whiteout on their chest x-ray, the wedge pressure tells you if it's ARDS, where the pressure will be low, or cardiogenic pulmonary edema, where the pressure will be very high.
And the ultimate mechanical supports.
There's the intra-aortic balloon pump, which helps improve coronary blood flow, but large trials have shown it doesn't actually improve survival in cardiogenic shock.
And then there's ECMO.
Right. And for cardiogenic shock, we use VA ECMO. This is different from the lung support ECMO. Here, the machine is acting as both the heart and the lungs, returning oxygenated blood under pressure into the arterial system. It's a life-saving bridge, but only for patients who have a potential long-term solution, like a heart transplant.
Okay, let's do one last check-in for everyone listening. Your patient has septic shock and severe ARDS. On the ventilator, their peak pressure is 35 and their PEEP is 10. Which pressure do you need to calculate the driving pressure, and why is that more important than the peak pressure? If you're not sure, rewind to our chat about Villi.
That's a great question to finish on.
So we have navigated the entire high-stakes environment of acute medicine today, from the ABCDEFGHI assessment all the way to advanced life support.
We've anchored some key ideas, using the balance of evidence for chest pain, learning to define the blackout and syncope, and we've grounded the critical care response in mnemonics like the sepsis 6 and the 4 H's and 4 T's.
I think the final takeaway really is all about time and prioritization. The goal isn't perfection, it's early recognition and rapid stabilization.
Which leads to a final provocative thought. We talked about the decision to admit someone to ICU, weighing the benefit against the suffering. The source material notes how technology is allowing us to prolong life in ways we never could before. So the question is this. Given our increasing power to support the body mechanically, how do we ethically define the point where pursuing physiological survival infringes on the quality of a human life? And what role should our objective scores, our NWS scores, our GCS, our physiological data play in these profoundly non-physiological decisions? Something to think about on the wards.
You're now well informed. We'll see you next time on The Deep Dive.